Well, thanks so much, Linda, and thank you to the Academy for this incredible honor. I would like to start by thanking Paul. Paul has been a tremendous mentor and friend, so thank you, Paul. And I must say I'm very humbled after these first two talks to speak to you this morning, but it's one of my passions now. And I'd like to tell you a little bit about value in healthcare, achieving patient-centered impact. And my objectives are to articulate the defining of value in healthcare in the Canadian context, the patient's perspective about value, and end up with a message about how the Canadian Academy of Health Sciences can catalyze action to achieve impact. So let's start with this concept of value-based healthcare. And most of you know Michael Porter's work, and in 2007 he addressed the Institute of Medicine in the US, and this is the equation. Value is achieving quality per unit cost. In 2010, he published in the New England Journal the following statement: achieving high value for patients must become the overarching goal of healthcare delivery. This goal is what matters for patients and unites the interests of all actors in the system. The IOM became the National Academy of Medicine, but over the years of 2007 to about 2014, there was a series of publications, a series of major assessments from the National Academy called the Learning Health System Series. And value in healthcare was included in that list. It started with the Learning Healthcare System concept. And when Victor Zhao became president, he instituted the comprehensive evaluation of many of these assessments and developed consensus reports, one of which was Vital Directions for Health and Health Care. This is an amazing comprehensive document that relies on previous assessments and the current state of affairs in the US. And it articulates some key action priorities and essential infrastructure needs. Pay for value, empower people, activate communities, connect care. And in terms of infrastructure, measure what matters most, modernize skills, accelerate real-world evidence, and advance science. And I can tell you that if you review the assessments from the Canadian Academy of Health Sciences, you will see all of these. Now, the influence of the National Academy of Medicine in the US is indisputable. And one of our goals in the Canadian Academy of Health Sciences is to emulate that kind of influence. But in Canada, we have a number of differences. Now, in 2016, the Economist Intelligence Unit did a country snapshot of value-based healthcare and used 17 indicators to compare countries and their ability to create value. These indicators included enabling policies in the institutions that manage that, measuring outcomes and costs, integrated and patient-focused care, and outcomes-based payment approaches. So Canada's rating was moderate, by contrast to a country like Sweden, which was very high. And the low scores for Canada were around, not surprisingly, things that we're quite familiar with and that Dame Sally has just articulated. We have no standardized disease registries. I'm not talking about repositories, we've got lots of those, but I mean registries. Minimal healthcare professional training in value-based care, and no national policy that supports organizing health delivery into integrated and/or patient-focused units, nor is there a national policy that encourages a management system to follow a patient through the entire multi-step episode of care. Partly that's because the federal government really doesn't manage healthcare in Canada. Our high scores, not surprisingly, we have universal healthcare. We have health-related research funding organizations with clear mandate to identify knowledge gaps. We've got some of the best clinical health sciences research in the world. And our provinces and health providers are developing things like interoperable EHRs. So the provinces boost our rating. But we have a long way to go to achieve what a country like Sweden has accomplished. In Sweden, everyone with over 90% of the people with diabetes are in registries, their outcomes are tracked, and their outcomes, in fact, are the best in the world. So I would contend that in Canada, our value in healthcare equation should look like this. We should be measuring outcomes that matter most to patients. And in the denominator, we shouldn't be looking just at direct health system costs. We should be looking at indirect costs as well. These are the societal costs, the costs to patients and their families. And I would submit that the Canadian Academy of Health Sciences has much to offer in this realm. The Frank Making an Impact assessment is in fact exactly the framework for measuring direct and indirect costs, not just in the context of research, although research is required to understand this value equation, but the payback framework that was articulated, the indicators, are very much part and parcel of what's needed to actually understand cost and outcomes. And you saw this, Dame Sally presented this slide to you already, but I'll present it again. The impact of this return on investment framework has been clearly in evidence in Canada and beyond. And a recent publication from the Canadian Health Services and Policy Research Alliance, Making an Impact, talks about the use of the framework. They've established a shared framework for assessing the impact of health services and policy research on decision-making, and this is what they say. The CHS Impact Framework is used by the National Alliance of Provincial Health Research Organizations, NAFRO, as well as a number of organizations, including the CIHR, across the country and internationally. And here are the 5 categories of this framework: advancing knowledge, building capacity, informing decision-making, health impacts, and importantly, broad socioeconomic impacts. And this framework includes informed decision-making as a component of the pathway to health, social, and economic return on research investment. This is what we need to be measuring that value. I'd like to talk a little bit now about patient's perspective. And this is a real patient, Ms. CL. She's in her early 60s. She's had type 2 diabetes for 40 years. Her ethnocultural background is Métis Francophone. She lives just outside of the Greater Toronto area on a disability pension, and she's on high-dose daily insulin injections. She has metabolic syndrome. This is what she says. Diabetes is not just about blood sugar control. It is about feet, eyes, and the effect of diabetes has on every aspect of my life. I often have to choose between food and medications as I'm on a disability and have a very limited drug plan. Even the copay is often beyond my budget. Every month I worry about whether I'll be able to afford the insulin I need. She does a daily foot check. In fact, she is deeply engaged in self-management. But she had a foot ulcer 10 years ago, so she's quite susceptible. And her diabetes clinic does not have a foot care program, and she can't afford the cost of a private chiropodist. Chiropody in Ontario is not paid for. She says, I live with the fear that I may lose a foot or that I may lose my sight. It's a constant battle for me every day. And this is taken from the Canadian Diabetes Association Ontario report. On the left-hand side, you see Charlene, and she is among the 1.5 persons living with diabetes in Ontario today. The direct cost of health care and diabetes for this province is $1.6 billion. Diabetes contributes to 30% of strokes, 40% of heart attacks. It's the most common cause of kidney failure for people going on dialysis, and it is the most common cause of blindness in working-age individuals. 70% of the non-traumatic lower limb amputations in Ontario are in people with diabetes, and that cost in Ontario is $500 million per year. Alberta recently did a survey on this topic and have presented very convincing evidence that at least 85% of foot ulcers that lead to amputations can be prevented. The work in Toronto recently looking at admissions to internal medicine in our academic hospitals revealed that the most costly admission to hospital is an individual with diabetes and a foot ulcer. It generates 3 times the cost of any other chronic condition, heart attacks, COPD, you name it, and it is the highest readmission rate. This is a huge health problem. The Public Health Agency of Canada in 2018 just published Key Health Inequalities in Canada, a national portrait. Diabetes is reported as a key health inequality indicator, along with asthma and arthritis and others. And that's because the prevalence of diabetes and its complications is higher in new immigrants, persons living with low income, those with a lower education level, of course, in our Indigenous population, 3 to 5 times higher than in the non-Indigenous populations. And if you consider inequalities by income and education level, the prevalence is higher in women than men. Not surprisingly, we saw the face of 3 women on the Ontario report in 2016. So from the patient's perspective, let's just look at the saga of diabetic foot care in Ontario. There's no provincial health insurance claim for physicians to examine feet. There's limited access to community-based chiropody or specialist wound clinics. Community-based chiropody is not insured. Health Quality Ontario has published excellent evidence-based standards for foot care, but there are no defined foot care paths in the community or in the acute care system. Fortunately, in 2018, the Ontario government passed legislation to pay for offloading devices for diabetic feet, the first in Canada. However, as I mentioned, the management of this in Ontario has yet to be devised. And Indigenous persons with diabetes in Ontario suffer 5 times the rate of lower limb amputation compared to non-Indigenous persons with diabetes. This is a huge problem and I think an issue to improve value in healthcare. So let's go back to our patient and fast forward 10 years. If there were no changes in the healthcare system in Ontario, here's what's going to happen. There's a very high probability that Charlene will suffer another foot ulcer and possibly have a lower limb amputation. She has progressive neuropathy and vascular disease. She's highly likely to develop either renal or cardiac failure. She is likely to suffer blindness or at least loss of vision, highly likely to become depressed because she'll be unable to sustain the level of self-management that she engages in today, and she will enter the 20% of the population that costs 80% of healthcare cost in Ontario. If we fast forward, and if the recommendations of Canadian Academy of Health Sciences assessments were adopted in Ontario in our healthcare system, here's what would happen. Charlene would receive ongoing specialist foot care to prevent recurrent ulcers. She'd have aggressive management of renal and cardiac risks with integrated primary and specialist care. She'd have frequent surveillance of her potential eye disease and necessary sight-saving interventions. She would be supported by her diabetes health professional and social service team to enable continued self-management and engagement in her community, and the investment in prevention and health promotion, which would cost money, would demonstrate a return on investment and saving in the healthcare system. I must say, too, again, if you go back to Sweden, you'll see that this kind of system has been established to a great extent in Sweden. It accounts for their much improved outcomes in diabetes. So what are these assessments I'm talking about? Well, the first one is Transforming Care for Canadians with Chronic Health Conditions, led by Louise Naismith and Penny Bellm. And this is what they said. Enable all people with chronic health conditions to have access to a system of care with a specific clinician or team of clinicians who are responsible for providing their primary care and for coordinating care with acute, specialty, and community services throughout their lifespans. And here are just some of the recommendations. This is an extensive report with lots of important recommendations, but let's just look at some. Aligning system funding and provider remuneration with desired health outcomes. This would mean, in Ontario, instituting chiropody-led diabetic foot care for the highest risk patients, including offloading devices. Ensuring quality drives system performance. All persons with diabetes have regular foot checks, and high-risk individuals would have that more often. In other words, segment the population and get them the right care at the right time, and report on standardized quality measures at a regional level. This is not happening today. Creating a culture of lifelong education and learning for healthcare providers. Understand the consequences of neglecting foot examination and care for diabetes patients. Here's another assessment, optimizing scopes of practice, that was led by Siobhan Nelson and Jeff Turnbull. Here's what they said. Identifying this, and this is from the report, they identified an emerging consensus that optimizing scopes of practice paired with supporting evolving models of shared care can provide a multidimensional approach to shift the healthcare system from one that is characteristically siloed to one that is collaborative and patient-focused. And this was a really extensive set of recommendations, a whole framework for transforming healthcare in Canada. And I'll just give you a snapshot. The framework is divided into micro, meso, and macro recommendations. Under micro, for instance, professional culture team vision to reinforce that the ultimate goal is the improved well-being of the patient. Who provides the care is secondary to the quality and accessibility of services provided. In the Ontario diabetic foot care saga, this would mean that persons with high risk of diabetic foot ulcers need multi-professional time and expertise with the primary care setting, a nurse practitioner, a chiropodist, a health system navigator, social services. In other words, a person with diabetes who develops a foot ulcer has an immediate biomarker of huge complications related to diabetes. At the meso level, communication. Implementation and upkeep of EMR is essential for all respective healthcare professionals and for patients themselves to have timely access to the most up-to-date information on treatment and status. Apply this to our system for diabetic patients. Diabetic patients would be tracked within and have access to an EMR system with alerts for screening and necessary intervention for prevention and management of diabetes complication factors and surveillance. This is like the system that you just saw in the UK, the Babylon system, similar. Finally, at the macro level, payment models, alternate funding, example, bundled or mixed payment schemes to include all healthcare professionals and to be aligned with desired outcomes. In the case of diabetes foot care, diabetic foot care requires financial support for all health professionals engaged in entire foot care pathway to prevent ulcers and amputations. There are huge gaps in payment right now, not just for diabetic foot care, but for many aspects of care in chronic disease generally. Here's another patient. This is Debbie Sismore, and she was the first patient partner we published on our Diabetes Action Canada newsletter in 2016. She's actually a member of our steering council. And this is what Debbie says. I've been living with type 1 diabetes for 50 years. She's just in her early 50s now. And lost my sight 25 years ago due to diabetic retinopathy. As a patient partner, this is with Diabetes Action Canada, I will be able to use my personal experiences from living with this disease to provide insight to the council. I bring to the table the experience of the diagnosis, treatment, and ultimately the devastating consequences of diabetic retinopathy. Now, Debbie doesn't fall into lower socioeconomic new immigrant categories. She is actually wealthy, but as her diabetes progressed, she did not have proper screening for retinopathy or treatment early enough to preserve her sight. This is the situation of diabetic retinopathy in Ontario today. 64% of individuals with diabetes are screened for diabetic retinopathy. This is unchanged for almost, I say a decade, but almost 2 decades. This means that 36% of people are not being screened properly. Debbie would fall into that category today. However, if you're a new immigrant, an Indigenous person, or a person living in poverty, you will have up to 60% probability of not having retinopathy screening. If you're over the age of 65 with diabetes, you fall into a category, a 3% category, where you will probably require urgent treatment to preserve your eyesight. So from the patient's perspective, this condition is entirely preventable with earlier screening and intervention. So, fast forward 10 years from today, and what could we see? We could see that diabetes complications like retinopathy, which are a product of high glucose and other influences like genomic, epigenetic, microbiome conditions, and what we should be able to see is proper population screening for predisposition to diabetic retinopathy, that all persons with diabetes are segmented into their risk, and that those at highest risk will have more screening and early referral for treatment, and we could prevent diabetic retinopathy. This has been done in England, BMJ report last year in southeast England and Wales, where 8 years ago they instituted population screening that was effective, and in this area of the UK, diabetic retinopathy is no longer the most common cause of blindness. It can be done. We've learned quite a bit about diabetic retinopathy, and by the way, all the complications of diabetes are somewhat different in their underlying etiology, although high glucose is the toxin. But in the eyes, we know that high glucose stimulates vascular endothelial growth factor, which in turn, through its signaling pathways, stimulates angiogenesis, and it's the new blood vessels that are created that cause the detachment of retina and blindness. Now, in Ontario, VEGF inhibitor therapy is paid for. It is the single largest class of drug cost, and it costs 6% of the total drug budget. Approximately 6% is about $350 million annually. And I can tell you that although this works, when you go to a politician or a bureaucrat and say, we need more of this, we need more screening, we got to find these people who've got this disease, they say, well, what is it going to cost? And that's a great question. What will be the return on investment for earlier intervention to prevent vision loss? And for this, we need team science. And you'll recognize the most recent assessment from the Canadian Academy of Health Sciences, the value of team science and how to optimize that within our academic systems. But for these complications of diabetes, we need to start with basic fundamental science and understand cause and be able to generate new drugs, new diagnostics, biomarkers. If you could do a blood test today for somebody like Debbie Sismore and understand what her predisposition is to retinopathy, you could get her into early screening and treatment and prevent blindness. But we also need clinical trials. We need population and public health. How do you get this screening into the population where it's cost effective? And health systems application of implementation science. Once you get a good approach, how do you scale it up? And how do you calculate that return on investment? We need all of this. And we have, in our academy, all of this firepower. I'd like to tell you a little bit about this trial, the BETTER trial. This is by one of my colleagues, Eva Grinfield. She is a primary care physician, but also a scientist. She leads research in the Department of Family and Community Medicine at the University of Toronto. And over the last 10 years, she and her colleagues have been engaged in building on existing tools to improve chronic disease prevention and screening in primary care. Why are they doing this? Well, it's pretty evident. Here is data from the US. It's the same in Canada. The lowest line there, you can see, is the increase in population over time to 2025. The lines above are the increase in the growth of chronic disease in our population: stroke, heart attack, cardiovascular disease, diabetes, hypertension. Chronic disease is the new epidemic. So, how are we managing this today? Well, the traditional healthcare model is to institute evidence-based guidelines for individual problems: diabetes, heart disease, osteoporosis, COPD, depression. But the reality is this: it is about the individual who has multiple risk factors and multiple probabilities of diseases that don't come in isolation. And the algorithms for screening, intervention, and so on are linked. And so this group said, okay, let's look at an opportunity to tackle chronic disease management in the context of scopes of practice. They wanted to improve prevention and screening in primary care setting, which is integrated across the major chronic diseases. So what did they do? They did a trial, a randomized controlled trial in 2 provinces, Ontario and Alberta, with 8 primary care teams, 32 family physicians, and 789 patients. This was their first study. They've done several studies since. What did they do? They said, well, let's start at the beginning with individuals coming into a primary care practice. And let's look at training a non-physician with specialized skills that would include an understanding of the environment, the community in which the practice was being undertaken. So that means specialist services, social services, and others. Look at the algorithms for the common chronic diseases and have those at the fingertips of these individuals. And train them in tools that will enable them to talk to patients, get this kind of history, and work with the patient in a shared decision-making framework for a prevention prescription that is tailored to the patient, but is based on standardized evidence-based practice. They called these people prevention practitioners. Most of them were nurses. And here's the bubble diagram. This is the framework. This is for a female, you can have one for a male, and so on. So, in summary, this is about cancer, diabetes, heart disease. You get a family history, you look at mental health issues, you look at all the risk factors, nutrition, physical activity, alcohol, smoking, and so on. And you design targeted targets with the patient that they'd like to achieve. And once you do that, then you send them into the primary care practice, and they can see a nutritionist, they can see a physical therapist, they can see a physician for prescription, say blood pressure medication or LDL cholesterol control, and so on. Or you can send them into social services if they need it when some of these issues are clearly related to social determinants. What did they find? So despite the fact that the original trial was not powered for individual outcomes, they showed improvement in all of these factors. A lot of them include screening, so screening was undertaken, but also targets such as physical activity and alcohol consumption and so on. They also measured the economic impact. And here they measured the incremental cost-effectiveness ratio for the extra cost, because this did cost money, for one additional action met. So an action met would be a new screening cost, a cost for consultation to a specialist, and so on. And in this table, you can see the control, so that was no extra intervention. PF, which is a practice facilitator. So some of these groups had already instituted workflow analytics and navigators and so on. So that was the practice facilitation. PP was the prevention practitioner. And if you added both the prevention practitioner and the practice facilitator, you can see the outcome. Very significant in economic value of these outcomes. I can tell you that this got the attention of health system and leaders and decision makers, and Ava and her team have been all over the world now showing these data. What are they doing next? They want to scale it up and study the scale up. So she and Donna Menke, her colleague who leads primary care research at the University of Alberta, are now instituting training for prevention practitioners. It's been launched this fall, and we're really looking forward to how these individuals can be deployed in primary care and understand the outcomes. I'd like to finish with this concept. It's a concept of collective impact. Now, one of the first publications about this concept was actually not in the healthcare literature. It was actually in the Stanford Social Innovation Review in 2011. And this is what the social scientists said. We believe that there's no other way society will achieve large-scale progress against the urgent, complex problems of our time unless a collective impact approach becomes the accepted way of doing business. And what did they mean? Well, they articulated 5 elements of collective impact. Creating a common agenda, keeping all the parties moving towards a same goal. Common progress measures or indicators, measures that get to the true outcome, what matters most to patients. Mutually reinforcing activities. Each expertise is leveraged as part of the overall. That's one of the beauties of the Better trial, showing how an increased scope of practice, particularly of a non-physician, can significantly improve outcomes. Communication, enabling a culture of collaboration. And finally, the backbone organization that takes on the role of managing collaboration. I would submit that one of the biggest gaps in the organizational structure of health systems in Canada is the lack of the backbone organization that truly functions managing collaboration among stakeholders, including patients. Now, the Canadian Academy of Health Sciences' promise is that we will inform actionable solutions that improve the health of Canadians by mobilizing the best minds. And you saw the inductees last night. We have over 700 members now from all the disciplines in health in Canada. What a tremendous brain trust, to quote Paul and John and others who have led this organization. And I would say that we're in a great position to create collective impact and an agenda that includes engaging our fellows in what they think matters most to them in their careers and can contribute to this mission. But we also need to engage national health leaders that will align with our mission, provincial health leaders providing solutions for their health strategies, and also begin to engage the public and private sectors in what matters most to them about healthcare, public health, and health systems. And I would submit that we are well underway. Here are more of our assessments that we've done. If you take a look at these reports, you will see that many of the solutions that are stated in our recommendations would truly improve the value in healthcare and achieve patient-centered impact. Thank you.
Tremendous, Kathy, and on behalf of all of us at the Canadian Academy of Health Sciences, thank you so much for your splendid lecture and leadership and enormous contributions. Thank you so much. So,